Hello and good morning. I'm Jakevia Wheeler, a public health researcher, and for nearly 5 years, I've supported the Glenn Family Foundation's community engaged research and program evaluation. I'm so very honored to introduce the first session of the day, as well as our first of 2 keynote speakers. This session is entitled Structural Vulnerability, Drug Use Risk, and Harm Reduction Responses, Caring Approaches to Enduring Problems. I am very proud to introduce our first speaker, Dr. Ricky Bluthenthal. Dr. Ricky Bluthenthal is a distinguished professor of population and public health sciences at the Keck School of Medicine at the University of Southern California. As the Associate Dean for Social Justice and Interim Chair of the Department of Population and Public Health Sciences, Dr. Bluthenthal has been at the forefront of community partner research since 1991, focusing on risk behaviors and health promotion among marginalized populations. With over 200 publications and numerous accolades, including the John P. McGovern Award and the William Foote White Distinguished Career Award, Dr. Bluthenthal is a leading voice in harm reduction and public health. Join me in welcoming Dr. Bluthenthal to the stage as he shares valuable insights into caring approaches to address structural vulnerabilities and drug use risks.
Good morning, everyone. It's interesting, I'm 60, so it's nice when you think, wow, that was a good introduction. Who is that dude? So, I'm really happy to be here. I've never been to Mississippi, and so I'm very grateful to the Glenn family for making that happen. I've had an amazing 24 hours so far, and I'll definitely try and find a reason to come back in the future. So let me just start with a little bit about me. So I'm a sociologist, and since 1991 I've been doing research with people who use drugs in community settings. I've looked at a lot of different health elements, including HIV, hepatitis C. We're doing a lot of work now on bacterial infections, and of course overdose. I've played a role in understanding the effectiveness of syringe service programs, other biomedical interventions like naloxone for overdose reversal, and then to a limited extent safer consumption sites. And then in my studies I use mixed methods, so qualitative and quantitative research, as well as, we used to take biomedical specimens, we sort of stopped that. But more importantly, when I was in graduate school, back in 1991, 92, I helped co-found the Oakland Needle Exchange program, and I ran that for 5 years. And I say importantly because for me, early in my career, I had the opportunity to do an HIV epidemiological study in Oakland and in the East Bay in California, and we found elevated rates of HIV, and I'm going to talk about that a little bit more today. But we realized no one was going to do anything about it. So people were dying, friends of mine were dying, and there just wasn't a response. And I'm not willing to live in a world where that was okay with me, and so I acted on that. And it's sort of been driving me the rest of the time, which is, science for science sake, doesn't exist, right? Science should serve some human purpose, some advancement, and that's what I've tried to do with my career. Okay, so I'm going to talk about, just briefly, structural vulnerability, where it comes from, and then I'll use 2 examples from research I've done, one a long time ago and more recently, sort of to illuminate how these sort of structures interfere with people's lives, and then talk about the alternative. So this harm reduction approaches, or what I like to call caring infrastructure, as a way of helping people address difficult and challenging problems. So my main points are, I'm a sociologist, so society matters and shapes a lot of people's life's opportunities. The other thing that I think is important, I feel like this gets lost in our political debates, our political dialogue, is that no change comes without a resource, right? Behavior change is really, really hard. In fact, my favorite saying about it is the only behavior change that's easy is when you change. Right? When I have to change, it's nail biting and sweats. It's really hard to do that. So if we want people to live differently, we need to give them the resources to live differently. And harm reduction is a great example of that. So it's creating the conditions where people can be safer and could thrive. And then the other point is, And again, this sort of, I think, you see this in our political dialogues just about problems, which is that a lot of times when we talk about problems that other people have, like the crime over there, or the drug use in this community or that community, what we're not doing is centering the people in those communities, right? And the truth is, and in my 35 years of doing this work, the one thing I do know for certain is that, you know, the answers are in those communities, that you need to center their perspective, center their experience. And when you do that, you can come up with ideas that are both effective but also sustainable. And I say that as someone who's been a very successful NIH researcher for decades. And one of the things we observed, for instance, with the HIV epidemic was we had a bunch of psychologists and sociologists and physicians coming up with very elaborate, intensive behavioral interventions that we discovered quickly don't translate into communities, right? Either because they don't have the professional, they don't have the technical capacity to do it, or the population isn't even interested in them, right? So they only work in research settings. So I just want to say that, like, at the end of the day, if you take nothing from what I have to say, the key point is that empowering the people with the problem is how you solve the problem, right? Giving them the resources they need to change is ultimately how the change happens, right? It doesn't, you know, us PhDs, we haven't had a good idea in decades, so. I'm being too honest, I'm sorry. We've had ideas though. Okay, so structural vulnerability, right? So it's this idea that individual and population groups have negative outcomes that happen at the interface of opportunity structures that are created societally, right? So the vulnerability that people have doesn't come, I mean, we all know people who make bad choices. We've all made bad choices ourselves, but, on occasion. But the point is that a lot of, when you look at it and you see a group of people suffering, it's usually not because they've uniquely identified people who make bad choices, right? There's something else going on that generates the conditions for that to happen. And the common things we talk about in sociology, things like redlining, residential segregation, underfunding of education, mass incarceration, all of these things harm communities, right? And they don't give them the resources they need to be different. So that's that structural vulnerability. And then the things that in our society drive those are structural racism. And I won't go through all the history. These are just some examples. And then structural violence. And so I'm going to talk about two groups, two sort of empirical cases. So one is HIV in Oakland among black people who use drugs. And then I'm going to talk about homelessness in Los Angeles, just to give you an example of how these things play out. The first case will be a historical one, and then the second one will be contemporary. Okay, so Oakland, California. So it's a map. This is redlining. So have people heard of redlining? Okay. I mean, it's not, I don't think it's a big, you're not, in Mississippi, you're not so urban, so it's probably not as big of a feature here, but in urban areas, it's a big deal. What's that? It's happening here. Well, yeah, I know. But was it just redlining though, right? So redlining was this idea that at one point, agents for the federal government in the 20s and 30s went around and sort of began drawing boundaries around neighborhoods, and they drew them based on the racial composition of those groups. And if you happen to be in a red area, which inevitably would be African American or Latino, then your capacity to get home loans and loans at all to build up the community would be diminished tremendously. And if any of you have owned a home, I've owned a house for 25 years, you know that if you're not like rebuilding it every 10 or 15 years, you don't have a home, right? So the devastation of not creating proper, appreciation of the property, the capacity for people to improve the property, created slum-like conditions. So that's what happened in Oakland. So you had these beautiful Victorian homes that were built in 2 centuries ago, in the 1800s, so it's like slowly decomposing. And so then you have this blighted area, and the city fathers say, okay, well, let's put the environmentally dangerous industry in that neighborhood. Let's put the water treatment plant in that neighborhood. The picture you're seeing at the bottom is where the 880 freeway is. So let's break up the community. So they just mowed down a bunch of homes and put a freeway in. And we know freeways actually, from a public health perspective, are pretty dangerous in terms of the pollution that they give off. So you've created these conditions of sort of disorder and despair. And then into that comes HIV via drug use. And so that's actually the first paper I wrote. So it's in JAMA. That's it. Start strong. And what you see here is the results of the studies that I did in East Palo Alto, Richmond, West Oakland, and then that the first author, John Waters, my mentor, did in San Francisco. And what you see in each of these cases is that elevated HIV rates in the areas that are African American, and then higher rates of HIV among the African Americans in those areas, right? So it looks like, and when I first started doing this work in the 90s, it looks like, oh, there's something wrong with black people, right? So I'm just going to cut to the chase. There's nothing wrong with black people. So if black people are suffering, it's not us. There's something else going on. And let me explain what was going on. So the first thing we did is we asked people about their risk behaviors. And so I'll just explain this. I probably need to change this slide. It means nothing to most people. But this is a cross-sectional analysis where we're trying to predict who shares syringes. And the top box sort of tells the story. So the fact that African Americans are under 1 means that African Americans are less likely to share syringes, which is how HIV is transmitted, than white folks as a referent, right? So you have this situation where black people are more likely to have HIV, but they don't have the behavioral profile that would explain that, right? So that's curious. And so then when you break it out by neighborhood, what you realize is that, well, it's not really black people, it's these neighborhoods, right, that were created by these conditions that are related to structural racism, right? So if you're an African American and you're in West Oakland, you're at elevated rate. But if you're white, you are too. And if you're Hispanic, you are as well, right? And if you're in a different neighborhood that doesn't have that history and those patterns of policing, then you're less likely to be HIV infected. All right? So it's not about individual behavior, it's about these sort of community conditions. And so we did some qualitative work just to sort of, explain this in a little bit better detail. And, the abandoned houses, in West Oakland facilitate shooting galleries, facilitate more efficient sharing when people do share, so you get, more rapid HIV spread. You have situations where you have, no policing and then a ton of policing. And that creates, problems where folks are more likely to end up sharing syringes. Social control is weak in the neighborhood. And then, you have opportunity for mischief, right? So this is sort of an example of how these sort of structural racism mechanisms take impact. And so I guess the second point I want to make about all of this is just that, these policies are choices, right? They're always choices. Like, we don't have to choose to behave this way. We don't have to choose to have policies like this that impoverish one group or impoverish an area at the expense of human health, right? So part of the goal, and when I talk about homelessness, I'll really bring this home, is that part of the people that need to change are the rest of us, right? Our political preferences, our policy preferences need to be different than they are if we want other people to be in a situation where they can achieve well-being and thriving. So one of the things that we've done, used, and this is a good idea from an academic, is this notion of ontological security, right? And so it's just a basic idea that for people to sort of have a self-identity, they need some constancy in physical and social support in their lives, right? So you can't break someone down. You can't deprive them of their family. You can't deprive them of education. You can't make it difficult for them to work or to have food and expect them to do better, right? Like when you say it out loud, it's like, yeah, of course. But we do that all the time with our policy choices. right? We find someone who's having a problem, and instead of like, hey, what do you need right now? And my favorite story about this, I was at a rally once in Los Angeles, and a guy who was like 21 talked about when he was 13, and the police stopped him at 2 o'clock in the morning. I have no objection to that, right? 13-year-olds should not be wandering around at 2 o'clock in the morning. But the question is, so what do you do next, right? What did he need in that moment, right? He didn't need to go back to the police station, right? Like, let's find out, what do you need, right? How do we get you back home? How do we get you under adult supervision? How do we get you what you need right now? And that's the question we should be asking ourselves all the time. It's not, why are they acting in this way we don't like? It's what is it that they need that they're not getting? And how can we help them get that? How can we enable them to be their best selves? All right, so in Los Angeles, I've been collecting data for decades. And one of the things we've realized is that homelessness has increased. Now, homelessness is complicated. A lot of it, just from a structural perspective, as a homeowner, I benefit, right? So we have mad, crazy property valuations in Los Angeles, right? So that's great for me, but it sucks for people who aren't me, okay? So you have a lot of economic inequality, this out of control housing market, and so that's created increasing levels of homelessness among people who use drugs. And so these are data just from a couple of different places where I've collected data in Los Angeles, and you can just see the table. In general, homelessness has increased. And then the next one is just about Chicago and showing a similar trend over time. So we have growing economic inequality in the United States, and particularly in urban areas, and then that leads to homelessness. All right? So then what we began doing was asking the question, for these folks who use drugs or who are unhoused, what happens when we do the thing that we like to do in LA, which is displace them, right? So we like to break up the homeless encampments, and there are reasons to do that. They're not the safest place on the planet, but what we haven't considered is what happens when you break them up, right? When you move people around. And so this early study we did, I think this data was from 2015, 2016, is you can see overdose risk increase, receptive syringe sharing increases, food insecurity increases. So basically lots of bad things happen to people when we disrupt them, right? So when you're thinking about this from an ontological security perspective, that kind of makes a lot of sense, right? We're disrupting people, making it harder for them to take care of themselves. And then of course the other thing that happens is even though we've made an enormous investment in Los Angeles in trying to address a homeless problem, you can't find people because you're moving them around, right? And so when the opportunity for housing or healthcare comes up and you've created a relationship with someone, you can't even find them again. So in new research, and this is just about to get published, we tried to look and see is there a dose-response relationship between moving people around and their sort of well-being. And so we sort of broke our sample up into these 5 different groups, so the small group of people housed, and then various levels of sort of being pushed around. And when you look at this table, what you see is, in generally speaking, the more you're moved around, the worse things are for you. So you're more likely to have overdose, you're more likely to report receptive syringe sharing, you're more likely to have difficulty getting clothing, finding food, difficulty staying clean, and finding restrooms, right? So the very policy option that my neighbors endorse is one that is making life harder for a population that's already suffering immensely. So I'd like us not to do that in the future. And then similarly, the same thing with violence, things being stolen. So, these folks, maybe not how, and I've never been homeless, but, I've seen a lot, I've talked to hundreds of people. It's awful. It's traumatizing. And, the thought that, okay, you're having your worst moment right now, and my response to you is I'm going to make it worse, right? That's what we're doing. Like, we're going to make it worse. We've really got to come to grips with this. And, if you're centering the perspective of the people suffering, you wouldn't do that. You'd figure, like, how do we make this encampment cleaner? How do we make it safer? How do we make sure you have access to running water and you're able to shower? Like, that's what you should be doing, right? How do we get you connected to the housing opportunities that exist, or to the mental health services you need, or to the medical care you need, right? But we got to do that while you're stable and you have people around that you trust, and you don't have to worry about having your things taken. But so we want to, on one hand, spend a fortune creating the infrastructure to do that, but then not disrupting the ability to deliver it. And then you can see, just from this next one, about the things that people lose. So that their clothing is taken away, they lose food, syringes, tents, naloxone, which is the medication you use for reversing overdoses, identification, which you kind of need to get social services, and then buprenorphine, which is the medication that we use from opiate use disorder. So we're literally hurting people. This is just more of the same. And so and I won't explain this too much, but the take home is basically the more we do this, the riskier people are in terms of potential overdoses, and in terms of syringe sharing, right? Which is how HIV and hepatitis C are spread. All right, so these are popular policies, right? So when I go out to dinner with my neighbors and I try to do my progressive, hey, we're hurting people, they're like, I don't want to see that, or that makes me feel unsafe, right? And I think part of the challenge for the rest of us in this society who have had the good fortune to not find themselves in these circumstances, is to care about someone else, right? To put them at the middle, the center, so that we can come up with policies that actually make it better for all of us, right? I mean, I don't like, in Los Angeles, Skid Row, it's awful. It's hard. It's a hard place to be. Whenever I go there, I do my food therapy because I'm so upset. Like I need to get some Philippe's French dip and have a lot of beef to try and overcome and stifle down the emotions of seeing people suffer like that. And we can make different choices, right? We can do things differently. And so one way, and people know what a harm reduction is, or kind of? Maybe not. Okay, so let's talk about it. So there are different definitions. I'm sure this is not on the webpage anymore, but this is SAMHSA's. The key point here is, to empower people who use drugs in their family with choices to live healthier, self-directed, and purpose-filled lives, right? So when bad things are happening to people, we need to empower them so that they can have a different outcome for themselves. So this is the one from the group I helped start, the harm reduction, national harm reduction, and you guys will get the slides so you can see the different elements of it. This is a more simpler representation of it, though. So, you put the person at the middle. It's client-directed, not judgmental, non-punitive, and practical, right? Dealing with people's basic needs, helping them identify the assets they have that can help them, and then giving them more resources to make that happen. And so when this stuff started, there's a real emphasis on low threshold strategies, which continues to be the case. But now I think there is more focus on power. I mean, having agency in your life, having resources to act on yourself and your environment, those are predicates to being healthy, right? When you have those abilities, you're going to do better. And so, a key point of the harm reduction advocacy is really justice center the experience of people who use drugs. That doesn't mean that other people's experiences don't matter. It just means if we want them to be different, we need to really listen to them. All right, so this is some research I did back in the 2000s, since I've been around a long time. And these are just sort of elements of how a needle exchange program might give out resources along the continuum of harm reduction. And so what you just see on the far right is, you have this, basically giving people what they need, right? You're at the site, you're trying to give them as many resources as possible when you've got them there so that they can benefit. And then this is a sort of empirical representation of this, and I'll try and explain this to you. So basically, on the bottom is deciles of how many times did you inject and how many times did you have a clean needle, right? So the CDC guidance is that every time you inject, you should have a clean needle. And so folks on the left side of that, the less than 10%, For every 10 injections they have 1 syringe. And the people on the right, for every 5 injection, or for every 1 injection, they have 5 syringes, 5 clean syringes, right? And then what's represented in the middle, the blue and the red, are syringe sharing behaviors. You see they go down the more syringes people get. And then in the middle is unsafe syringe disposal, which is a thing that people are concerned about. And that actually goes down as well. But basically, you can be generous. The point of this slide is you can be generous and not have the unintended consequence and have the kind of behavior change that you want to see people have, right? So you give them the resource, they use it the way you would intend it, and they end up better off. And this is sort of just another take on that in terms of the programs. And what you can see is the programs at the top that have unlimited need-based distribution, their participants are more likely to have adequate syringe coverage, and it sort of goes down the more restrictive you are, right? And now recall, in this society, when we give out, when we want to help lower income people, we often put all kinds of restrictions on it, right? And we're like, oh, we need you to be accountable, and we need this, and we need that. And the truth is that accountability usually costs something, right? And so it means it's less resources available, and it doesn't help people as much, right? So my argument is we just need to be generous. And we're a wealthy country. We can afford to be generous, although some people will tell you that is not true, but we can afford it. And when we are, we'll be more effective, right? So the cost of the stinginess is not being effective. And then similarly, this is just more data about providing services at these sites. And essentially, and again, you can look at this on your own later. But what this is showing you is that if for these populations, if you're not providing it a needle exchange program, they're likely to not get it, right? So the primary care, tuberculosis screening, access to preventive services, it all works. All right. So then, we're in the midst of this decades-long overdose crisis. And one of the most important conduits to get naloxone to people who use drugs are needle exchange programs. And so this is sort of a map talking about the naloxone distribution from the earliest period, 1996 to 2014. And, what you see is, giving the medication that reverses overdoses to people who use drugs is the most effective way to reverse overdoses, right? Because they're there, right? They're there with the other people who use drugs. And when you give them the resource, you get reversals, right? When you empower them, you get the outcome you want. This is a better slide of it. I like this one a little bit better. And so essentially, there's sort of 2 cities represented here. So the 3 on the, I made my right, your right? Yeah. Are San Francisco, and the 3 on the left are Los Angeles. And then these are 2 different time periods. So 2011, and then the other period is 2016. And so you see in both cities, overdoses, non-fatal overdoses went up. Witnesses overdose went up. And this coincides with the introduction of fentanyl into these 2 communities. But more importantly, what you see is naloxone use really went up. So in Los Angeles, we really began finally catching up to San Francisco and making naloxone widely available to people who use drugs. And then you get this great increase in the amount of naloxone that's being used. These are lives that are being saved in real time, right? Like, in Los Angeles, you tell me you want to spend money on the fire department, sign me up, right? Sign me up. You want to spend money in overdose prevention? We need to give it to the people who use drugs. Give naloxone to the people who use drugs. They're better than the fire department, right? There's thousands of people saved. Thousands of people saved, right? So it's an amazing return on life and investment. So let me just make this point, and I sort of boo-hooed PhDs, and I can do that because I'm almost done. But one of the things that's been really important for me to recognize, and I've been humbled by, is the fact that most of the ideas around preserving the lives of people who use drugs have come from people who use drugs. They have not come from the PhDs. And in fact, I was with Dan Bigg, who is sort of the godfather of naloxone distribution in the United States, back in the mid-90s, when we were in a meeting and he came in with his duffel bag full of naloxone. And I'm like, what's that for? And he's like, this is the medication that reduces overdoses, and I think we should be giving this to people who use drugs. And I'm like, really? So there you go. That's your distinguished professor. So it's a great idea. It came from someone who was himself a heroin user and died from an overdose, unfortunately. Okay, so policy and programs that disrupt physical and social conditions inhibit the capacity of individuals to achieve well-being. And again, we don't have to do this. So I'm going to show you just really quickly some data from a qualitative study we did with the Law Enforcement Assisted Diversion Program in Hollywood. And we interviewed people. And so the key feature about this program is because it was funded by the National Institute of Justice, the case managers had ridiculously low caseloads. So there was like 5 to 10 people per case manager. So they could really get in there. And then the other thing was that they were like harm reduction superstars. So they were willing to go wherever, do whatever to help somebody. And so here, I'll just take you through some of the slides. That they're really sort of trying to mend the safety net. So, they're basically case managing their other case managers, making sure people make appointments, holding on to their phones, delivering medications to them when they need it. And when you're when you're unhoused and your life is disrupted and you're getting assaulted by society and then the people around you sometimes, it's hard to be organized, right? It's hard to make appointments. So they were sort of doing a lot of that heavy lifting, and they did that through, relationship building. We had a process where they were helping people get rid of warrants because the city prosecutor was involved. And then when even people would get housed, they would help them figure out how to be housed again. So there was a circumstance where one woman got housing, and I don't know, homelessness it's an issue here, yeah? Yeah. So, so people can become hoardy, right? They hoard stuff. And so she was doing that in her apartment, right? So we've all lived in apartment buildings. That's not cool. So the case manager would come in and help her figure out how to not do that, right? So she could stay housed, right? And, people need that kind of help because being unhoused is traumatizing. The other thing is that connection, right? Staying connected to people. One of the things that happens when people become unhoused, obviously their friendships collapse. You often lose connection to family. And so you have this person that you can rely on. And so the story I like to tell is there was a transgender woman who was in residential treatment in Hollywood. And the treatment facility had a security problem, and so they had to close down. And so this woman needed to find a new treatment facility, and they offered one, and she had been in it before and did not have a good experience. And so the case manager's like, well, let's not do that. Look, let me get you a hotel room. Where do you want to go right now, though? Where do you want to be right now? And she's like, well, I grew up in Huntington Beach. Can we go down there? So he's like, yeah. So he drove her down there. He got her a motel. They hung out on the beach. And then she goes, I'd like to talk to my mom. He's like, all right. And so he called up her mom. They connected. He dropped her off. The next day, she spent the day with her mom. Right? Meanwhile, him and his team were working the phones to find a new place for her to go. And by Monday morning, they had found it. And so they went down, picked her up, and put her into a new residential treatment facility. So I'm very moved by that story because I think it highlights, they've been through or are in hell, or our version of it on this planet, right? We got to change. I mean, we have to go the extra mile if we want their lives to be different, right? Because they're under assault. And we have to stop pretending like their desperation means they should take whatever we give them, right? Because we know that doesn't work, right? If it did, we wouldn't have these problems, right? So we have to be willing to extend ourselves. So that what we learned from this is that fostering these relationships, doing this emotional labor, connecting the disconnected social service system was key to these people achieving reasonable outcomes, and sometimes incredible outcomes. All right, so let me just finish up. When I got started in this work years ago, HIV was killing people every day. And I was really focused on preventing HIV. And what I've learned is, like, diseases come and go, but people endure. And so we really do need to focus on the people first and what are their, physical, emotional, material needs. The other thing is that we have to focus on systems. Again, look, we all have, most of us probably have great stories about ourselves. I have a great story about myself. Like, my teenage mom, I don't know who my dad was, born in the county hospital, and look at me now, right? But I didn't get there just because I'm like really smart. Maybe I am. But I'm really lucky. And I had a loving mother and an amazing stepfather. And people saw things in me and told me about those things. And I listened to them. And then my life got better. And then they gave me resources so I could achieve my dreams. That's how it happens for all of us, right? That's a system. So in my case, I didn't need the government to intervene because I had good people around me. But not all of us are that fortunate. Right? And so if we're going to the rest of us need to sort of lend a hand in that. We need to ask ourselves, are these systems that we're really committed to helping us achieve the ends that we want for the people we care about? And I think a lot of times they aren't, to be truthful. And that there are other ways to do things that would get us better outcomes. All right, and then, we need to prioritize the populations that are having the problem. So again, my neighborhood is a great example of that. It's an affluent area. Yeah, there's some homeless encampments around us, right? They're not bothering anybody. They're not, right? We don't like to see them, but folks in my neighborhood mobilize all the time to get rid of them, right? And it's not part of the solution, right? We need to look at it from the potential. We need to prioritize the population that are having the problem, not the folks that have the political connections, which is what we often do. Yeah, so I think that's it. Be nice to people. That's my take home. Thank you very much.
Thank you so much, Dr. Bluthenthal. We'll now enter into the question and answer portion for this segment. You'll notice that we have 2 microphones on each side of the room. If you have a question for Dr. Bluthenthal, please feel free to make your way to the mic. I'll ask a question in the meantime. So I appreciated your perspective so much on, not conducting science for science sake and needing to center community in our approaches to addressing their problems. Understanding the reality that there are so many barriers with researchers, practitioners, people who are doing community health work. There are resource constraints, there's stigma, all sorts of things. So what would you recommend people do to really make that connection with community to actually support them in being the solutions to their challenges?
Okay. So from the perspective of researchers, I think the truth is that we have to spend more time in community, right? Like, you have to build the relationships and walk the walk and, show up for dinners and go to town halls. So that's easier. I think in terms of people who are providing direct services to folks who need, I think we have to realize that the system that you're in is not set up to maximize the benefits of the people you're working with. So you don't have a moral imperative to follow their rules necessarily, because the rules aren't predicated on what's the best possible outcome for the person in front of you. So I encourage people to be creative. I broke the law. I'm not saying you need to do that, but there's a person in front of you who needs help. Try to help them the best that you can, and don't get caught up in the bureaucracy and the sort of what is really fake accountability. Because those things, they exist for a different political purpose than the outcome of improving the health or the outcomes of the person you're working with.
Dr. Bluthenthal, thank you so much for that awesome presentation. But I have a couple of questions that I'd like to ask of you. You made the statement at the onset of your talk that it's not so much about individual behaviors, but about conditions in communities due to structural barriers. So I'm curious to know what you would say to the skeptic, or how would you instruct or convince the skeptic who insists that substance use is a choice, despite the deficiencies within one's community construct.
Yeah, and I wouldn't disagree with that premise. Substance use is a choice. Most of us use substances, right? Food's a substance. Nicotine's a substance. Alcohol's a substance. People want to be able to change their moods. So they're not wrong about that. What you have to contend with is the fact that, look, I went to UC Santa Cruz in the 80s. There's a movie called Dazed and Confused about it. There was a lot of drug use at UC Santa Cruz when I was there. And there continues to be, right? But what you don't see is a bunch of UC Santa Cruz students getting arrested, right? So I think there is a policy choice we made around drug use in lower income and minoritized communities to treat that substance use with criminal legal intervention, and it's not an effective way of addressing substance use. So yes, substance use is a choice, but if you're in an environment where you're criminalizing it, it makes the consequences of that choice much worse. So that's one point. And then I think the other piece is, look, and I'll do a dad thing. So I have two daughters, adult daughters, 23 and 25. One of them has used drugs. I'm not crazy about it, but she's also well-resourced. So she hasn't used them in dangerous situations. She stopped using them now. And that's because there's information and people and access and other great things going on in her life, so that this drug use doesn't be like, my life really is awful right now and I need to feel differently, right? And it's funny, if you read sort of qualitative accounts of people like using heroin for the first time, they're kind of moving. People describe it as like the light came on and I finally felt good about myself for the first time, right? That's a powerful narcotic. Other than Jesus, right? You know what I mean? That moves people. But if you're in a context where there's lots of other good things going on, it wouldn't have that kind of impact on you. And so I think that resource environment really matters. And then the policy choices and how we have treated different communities differently for their substance use matters.
Thank you for your feedback. I have a similar question. I wanted to speak more specific to the implementation of that, because we know that some judges, even in this area, they have more punitive approaches to addressing drug use, drug abuse. But when we come to that choice component, that is a barrier that we have to really break through. Whereas we have some judges that get it, some don't, and then they throw the book at them with these punitive approaches as opposed to a diversion program. So I'm curious to know about what that looks like and what steps that we can use to implement that.
Yeah, I think the question you need to ask those judges is, is it the thing you're doing working? The person you just threw a book at, are they better off? Are they going to be better off 5 years from now, 10 years from now? I can tell you the answer is no, they are not going to be. Putting people in jail merely for substance use, what are you doing? You're taking them away from their family, right? You're taking them away from their intimate relationship. You're taking away potentially from their children. You're diminishing their education outcomes. You're harming their employment viability for the rest of their lives, right? You're completely setting them back, right? And when people come out of jail, they've got a new set of friends who also have the same kind of problems, right? If we thought about jail as an intervention, it would be the worst intervention we've ever devised. Like if it was in a clinical trial, you would stop it because you're harming people, right? So that doesn't mean there aren't some people who need to be in jail, but if they're there just for substance use, you're just making it worse. And I think we just need to keep communicating that message. It's difficult and politically hard to. Like, I was in the state capitol in California a couple weeks ago trying to argue against enhanced penalties. I did not enjoy success in that. But I wasn't wrong. We had 3 strikes in California. It didn't make us safer. It just put a whole lot of people in jail. And that undermines communities, right? So, yeah, I think you just got to keep working on them.
Thank you.
So my second question. What creative strategies could you share to employ harm reduction methods in light of funding cuts, departmental downsizings and closings, funding reversals, and and the like? What are you guys doing to overcome?
Well,
some of
the big thing in LA is mutual aid. So it's people, with some resources, donating to groups, and, creating community with folks. So that's one thing. Your foundation is a great example of that too. The Glenn Family Foundation, I think, is a great example of that, of being present, knowing the challenges, and then trying to find other resources, whether they're from industry or donations, to continue the work. When we started the Needle Exchange program in Oakland back in '92, yeah, we didn't have any money. No one got paid. We just, all the money went to syringes. So you do what you can. But I think you can do it knowing that engagement with community and with people is where the solution can be found. And the truth is, look, the government's weird right now. It won't be weird forever, right? It'll swing back. And we just need to go even harder around having solidarity with people who are suffering and trying to give people the things that they need to have a better life. All right. Thank you very much.
Thank you very much.